Appendices do appear in the very back of your CPT-4 book. You have an Appendix A, which are full-blown modifier descriptions that I would highly suggest that you read. I'm going to bring your attention particularly to modifier 59 and modifier 51. And we'll talk more about those modifiers, but for now, if you can zero in on that and read through those. Appendix B, CPT code additions, deletions, and revisions. Appendix C are clinical examples that you can read through, particularly as it relates to evaluation and management codes. Appendix D are your CPT add-on codes, and Appendix E are your CPT codes that are exempt from Modifier 51. Modifier 51 is multiple procedures performed at the same time of operation, and your Modifier 59 is separate and distinct, where you have a different site, different physician, and a different procedure that took place. And again, I'll accent more and more on those two procedures. Modifiers. The modifier 59 should again be sparingly used. This is a red flag, if you will, from a payer's perspective, that they may audit you and pull a report as to how often you use this particular modifier and if you're using it correctly. Okay, these are common coding conventions and symbols that are used in the CPT book, and if you want to, you can access them also when you in the front cover of your CPT-4 book. I'm going to come back. The semicolon is a common root or stem, and how I explain this is when you are looking up codes, and I want you to look up, I gotta find you a good example where you can look up a code and you will have a primary code and then you will have some subcategory codes. Look up the code 36511. 36511. This is therapeutic apheresis, and you will see a semicolon. And then after the semicolon, you see for white blood cells. So in reading the descriptor of this particular code for 36511, that is how you would read it, therapeutic apheresis for white blood cells. But if you were to have therapeutic apheresis for red blood cells, then you would need to use the code 36512. So, and really how you do this is, it's like shorthand in reading this. Your parent code, if you will, is the 36511, where it has the therapeutic apheresis semicolon. So in essence, it's that semicolon is telling you to stop, and then you need to code with the specificity of what was used with that therapeutic apheresis. So if it said therapeutic apheresis for red blood cells, then you would only use the code 36512. I often get asked, well, why don't I code both 36511 and 36512? And again, the intent purpose of that semicolon is simply really the whole description of 36512 is therapeutic apheresis for red blood cells, but they didn't write it because it's for I guess time and space, saving time and space. Instead of rewriting it over and over and over again, they developed this semicolon to indicate that that's where you stop and then add the specificity of the following code. So this is explained also in your Fallon book. I would encourage you to locate this concept and understand it very well, because a lot of people, they do get mixed up with this and provide me two codes when in fact I only needed one code for a particular situation. And I am looking here to see what example. Okay, if you look on page 19, it says when you see a semicolon in a CPT code description, you should immediately stop. The information preceding the semicolon serves as a common stem or root for the information that follows. So each indented code after the root or stem will provide specific information to complete the stem. So the semicolon is a convention used in the CPT manual to prevent repeating the information contained in the stem for every code description. So the example that they gave you was a 25100, which is an arthrotomy wrist joint, and I'm going to stop, and with joint exploration, with or without biopsy, with or without removal of loose or foreign body. So if that is the code, I would just simply code it 25101. I would not code it 25100 and 25101 because again the semicolon, the stem, would be included in the description of 25101, and the stem here would be arthrotomy wrist joint. Okay, so it's important that you understand that concept. The other symbols listed here, you have bullet, which means new codes to CPT, triangles, which are indicative change in the code description, facing triangles, which are new or revised texts, plus symbols are add-on codes, circled bullets are conscious sedation, null symbols are modifier 51 exempt, and then your lightning bolts or pending symbols is pending FDA approval. All right, so the Uniform Ambulatory Care Data Set, the UACDS, this is what I was sharing with you earlier on, where this provides a standard, consistent set of data elements that are captured to code. It enables the providers to compare common data sets across the United States, basically. It is recommended for the National Health Information Network. It is aimed at improved quality of care and reduced errors in medical care. So again, the Uniform Ambulatory Care Data Set is for the outpatient setting, and you'll learn that the UHDDS is for the inpatient setting, and we'll talk more about that data set when we talk about inpatient coding. So again, the importance here is that this data set for the outpatient arena provides a uniform ambulatory care data set that provides the provider to capture and standardize their coding practices so that we can compare data. If you can think of, if we didn't have this standard data set, our data and research would be skewed because we would have no consistency in the data. Okay, so it's extremely important. This code to the highest level of certainty is a cardinal rule, if you will, of CPT. Inpatient coding does allow diagnosis coding of possible, probable, questionable, rule out, and suspected conditions. However, on the outpatient side of things, they do not allow coding of these diagnosis codes. Now let me give you an example. Let's say possible myocardial infarction. On the inpatient side, the convention tells you that that possible MI is going to be coded as if it were, as if it happened. On the outpatient side, that's not the case. You're not going to code that possible MI. Again, you're only coding to the highest level of certainty, meaning you code to what you know during that particular point in time in the outpatient setting. In the inpatient setting, you have the ability to run tests to confirm, in fact, that patient had an MI. You have the ability to run an EKG. You have the ability to run tests and hold these patients in what they call observation states so that you are able to use that diagnosis code for the inpatient side. On the outpatient coding, you will not. Now, let me also, there is another difference. On the outpatient side, your first listed diagnosis code is considered the primary diagnosis. The primary diagnosis is the term that's commonly used to describe the first diagnosis that's sequenced for outpatient reporting, meaning it is the reason for that patient presenting for care. On the inpatient side, that first listed diagnosis code is referred to as the principal diagnosis code. All right, so on the outpatient coding side of things, again, the highest level of certainty allows outpatient coding of signs and symptoms or abnormal test results. Really, you're coding at that point in time, whereas on the inpatient side, you have the ability to run tests and you have the ability to code to the highest possible specificity for that particular situation. So there is a difference again between inpatient and outpatient coding. And if you take a look on the example on page 21, if you have a diagnosis of cough and fever and it says rule out pneumonia, for an outpatient encounter, the diagnosis is going to be your cough and fever. For the inpatient visit, the diagnosis is going to be pneumonia. Because again, rule outs, possible probables, they are going to be coded as if the condition existed. That's a convention. That's not you making things up. That's a convention that you need to follow as a coder. All right, so this just reiterates what a primary diagnosis is. It is a first diagnosis that's listed for outpatient reporting. It is the main reason for outpatient encounters. Post-operative diagnosis should be used if different from a pre-operative diagnosis. And then additional diagnoses are coded if they do affect overall care of the patient. Okay, so again, the purpose of CPT and Level 2 HIC-PICS modifiers, really the modifiers, they don't change the basic code description. They really add and help explain special circumstances that may change the reimbursement of that particular procedure code or that procedure service. Modifiers can also specify a body location. So if you look in the cover and you find RT and LT, RT and LT, and the usage of those modifiers is the rule of thumb is if you have two of them on your body and only one of them was provided a procedure, then you do need to specify that part, so to speak. So you have two ears or two eyes, or let's say two legs, and the procedure was done only on the right leg, then you do want to put RT at the end of that 5-digit CPT code. Now, next, I often get asked, well, how do I write it? So you're going to write your CPT 5-digit code with a hyphen and then a capital R and a capital T. Modifiers are always 2 characters. They can be alphanumeric, they can be alpha-alpha, or they can be numeric by themselves. All right, so understanding modifiers, again, I'm going to reference the Appendix A of the code book, which gives you detailed definitions of modifiers that are provided. Each section of the code book does begin with your guidelines. They are green pages, if you will, that I would encourage you to read through, and they will contain unique modifiers that are unique to that section. Inside, the front cover of some code books provides an at-a-glance listing of modifiers and brief descriptions of them. Again, the full listing of modifiers are in your HIC-PICS book, and then also your numeric modifiers, you want to access Appendix A in your CPT book. All right, so for specifically in using CPT modifiers, and again, novice coders, they do struggle with this a bit on how or when to use modifiers. So I want you to look on page 22, and in there's some general rules to follow on knowing when to add a modifier or not. It says general rule to decide whether or not to use a modifier. You want to start with a CPT HCPCS code and ask, are there unusual circumstances involved? Is there more specificity in the documentation than in the code description itself? Is there increased or decreased time that's involved? Are there increased or decreased resources than intended by the code? And if you have yes to any of these, you want to look for the applicable modifier. And if you say no to any of these or no to all of them, then a modifier is not necessary. So looking at modifier 21, this is prolonged E&M services. This is a modifier specifically for used only with the highest level of the E&M code. It exceeds the typical time by at least 15 minutes. It's not used with your critical care or neonatal intensive care. It's not used with the prolonged services add-on codes, and it does require special report detailing time and reason for prolonged services. Again, if you want, take a look at page 23 in your textbook. It gives you an example as to the correct code plus the correct modifier to use. Okay, actually modifier 22 has the example and correct code plus modifier. This is unusual procedural services. Okay, it indicates a service that is required significantly more resources than is typical. So the example given was surgeon removes a 2-pound cyst from the pancreas of a morbidly obese patient. The surgery was complicated because of a poor visual field attributed to the patient's obesity. So the procedure was excision of the lesion of the pancreas and with unusual circumstances. So due to the size of the lesion, it's a 2-pound cyst, the code that you would put is 48120. How you would find that is you can look under cyst adenoma and then add modifier 22. And again, modifier 22 is not to be used with E&M codes. All right, 23 is unusual anesthesia, and this is where it indicates general anesthesia is used when no anesthesia is normally used. So again, you're explaining extenuating circumstances of why general anesthesia needed to be used. So this example was patient with bipolar disorder sustains a closed fracture of the ankle during a panic attack. Patient becomes agitated when the physician prepares to set the fracture and does not respond to efforts to calm him. Anesthesia is administered so the fracture can be reduced without the patient causing himself further injury. So again, you are going to look under anesthesia. Anesthesia for all closed procedures on lower leg, ankle, and foot is going to go to 01462-23. All right, looking at modifier 24, this is unrelated E&M service by the same physician during a post-op period. Post-op means after the operative session. So this modifier is used if an E&M service that is not related to a surgical procedure is performed by the surgeon in the post-op period. This modifier is only used on E&M codes, and a special report is going to be necessary when filing for reimbursement. So an example here would be patient receiving or recovering from a C-section with complications presents to her OB-GYN's office complaining of a vaginal yeast infection. So this would be an office visit, a 99212-24. Modifier 25 is significant separately identifiable E&M service by the same physician on the same day of the procedure or other service. This allows a physician to bill for an E&M service that's not related to a procedure performed on the same day. Again, 25 is only used with E&M codes. An example would be physician repairs a laceration on a patient who also is experiencing severe asthma symptoms. A simple repair of superficial wounds of the scalp, 2.5 centimeters or less with separately identifiable E&M service. So you would code the 12001, which is the repair of the superficial wound, and then you have the separate identifiable office visit addressing the severe asthma symptoms, which is the 99212-25. Okay, the 26 is a professional component that's used by physicians who uses equipment and staff of a facility. It contains only the professional component, meaning the physician is reading or interpreting the x-rays that are taken, or it's used with some radiological procedures and other diagnostic tests to indicate that only the professional component is applicable. Physicians with their own radiography equipment and radiology technician on staff submit the appropriate code without a modifier. So again, if they're only reading or interpreting the x-ray or radiology film, then that's when they would apply 26, the professional component. The technical component for the facility side in billing for the actual film that's taken under the roof of the hospital is TC. So again, 26 is generally used by radiologists who do interpret films or cardiologists who interpret ECGs. Okay, 32, modifier 32 is for mandated services. This is used when an official entity requires a service to be performed. An example would be, after determining the patient's willingness to cooperate, police ordered a local psychotherapist to perform hypnotherapy on a witness to a hit-and-run car accident to see whether the witness could recall more details, such as license plate number under hypnosis. Hypnotherapy is 90880-32. In essence, it's a mandated service. The patient is agreeing for it, but to explain to the payer that it was mandated, that's why you want to put modifier 32 on there. All right, 47, modifier 47, anesthesia by surgeon. This is appended to surgery codes to indicate the surgeon has administered general or regional anesthesia. An example would be, after the initial prep, patient complained of extreme pain and a decision was made that general anesthesia would be used. Surgeon administered the general anesthesia and performed the colonoscopy on the patient. Colonoscopy, flexible, proximal to the splenic flexure. It was diagnostic with or without collection of specimens by brushing or washing, with or without colon decompression, general anesthesia administered intraoperatively by the surgeon. So the actual code would be 45378, which is the colonoscopy, and then you're going to append modifier 47 on there to indicate that the surgeon did the anesthesia. Okay, modifier 50 is bilateral procedures. These are procedures that may not include bilateral in their description. So if you are coding a procedure that was done bilaterally, however, it's not accommodated, the word bilateral, in your description, then you would be able to use this modifier 50. Procedure is done on both sides of the body. Some payers do prefer listing of the procedure code twice, once with the modifier and once without. Some payers prefer the code to be listed twice with the modifiers LT and RT being used. So again, it depends on the payer. An example would be, patient presents with an abscess in both the right and left ear canals, and physician performs a drainage procedure to eliminate each abscess. Drainage, external auditory canal, abscess as a bilateral, both ears procedure. 69020-50. And really what you're going to learn when we do discuss auditory procedures is that the intent is done on both ears. So if the procedure was done just on one ear, then that would be a reduced service, which would be modifier 52. Okay, modifier 51, multiple procedures, is used when more than one procedure is done in an operative session. You want to list the most significant procedure first. You cannot use modifier 51 for codes that have the exempt from modifier 51 symbol, and you cannot use with add-on codes. An example of this one would be patient has stab wounds to the neck and chest. Physician performs an exploration of a deep penetrating wound of the neck and a lesser wound of the chest. So you're going to document the 20100 and the 20101-51. This is 51 is used for professional services only. It's not used by hospitals for the technical component. Modifier 52 is for reduced services. It's used if full services described by the CPT code were not performed. 53 is a discontinued procedure where you want to use if procedure is started but discontinued. Usually occurs during or after anesthesia administration because of the change in the patient's health status, and it's used only by the physician. An example would be surgeon begins the procedure for a ureterostomy. After the incision has been made, patient experiences an anaphylactic shock from an unknown allergy to the anesthetic. So the procedure is immediately discontinued. So in this event, again, they started the procedure, anesthesia was administered, so you're going to put 50760-53. Key term here is the procedure was started, it was started, and also the key term is that anesthesia was administered. Modifier 54, surgical care only. This is when the surgeon performs procedures but does not provide post-operative care. An example would be a specialist performs a ureterostomy at a hospital 200 miles away from the patient's residence. Patient is discharged with instructions to have his own physician manage the post-op care. In this case, it would be 50760-54. Modifier 55 is for post-operative management only. Physician does not perform surgery, only provides the post-operative management. Next is modifier 56, which is preoperative management only, where the physician provides preoperative care but does not perform the surgery or provide post-operative care. Modifier 57 is for decision for surgery, where it's used with E&M codes or general ophthalmology codes to indicate visits that resulted in the decision to perform surgery. So an example would be where the surgeon conducted an office consultation based on a referral from the patient's primary care physician and made the decision that resulted in surgery. The code would be 99202-56. Modifier 58 is staged or related procedure or service by the same physician during the post-operative period. This is used when a second staged procedure is planned to fully treat the condition. An example would be patient with a wound to the neck has an initial surgery to repair the wound and returns within the post-operative period for a flap graft of the neck. The graft would have this modifier appended. It would be 99241-58. I'm looking, okay. Okay, modifier 59 is distinct procedural services. This is used when two unrelated procedures are done on the same day. An example would be, under certain circumstances, the physician may need to indicate that a procedure or service was distinct or independent from other services performed on the same day. Patient has a diagnostic arthroscopy of both the left elbow and left shoulder during the same session with an orthopedic surgeon. 29805-59-LT and 29830-59-LT. Modifier 62 is when two surgeons, both surgeons work as primary surgeons. Let's see, an example would be a neurosurgeon and orthopedic surgeon work together to perform separate parts of a surgical laminectomy with sections of spinal accessory nerves. So the code would be 63192-62. Modifier 63 are procedures performed on infants that are less than 4 kilograms. This is where an example would be a repair initial inguinal hernia preterm infant performed from birth up to 50 weeks, post-conception age with or without a hydrocelectomy. Again, your documentation needs to be pretty. Okay, modifier 66 is surgical team. It's used when several physicians, often from different specialties, participate on a surgical team. Example would be 3 specialists perform emergency repair of a thoraabdominal aortic aneurysm with graft and with cardiopulmonary bypass surgery. Code would be 49491-63. Again, the 66 is used for when several physicians, and they're often different specialties, participate on a surgical team. 76 is a repeat procedure by same procedure. It's used when the same procedure is performed twice in the same day by the same physician. Modifier 77 is a repeat procedure by another physician, where it's used when the same procedure is performed twice in the same day. The second time was done by another physician. Modifier 78 is returned to the operating room for a related procedure during the post-op period. You want to use this modifier to resolve a complication from the first surgery. 79 is unrelated procedure or service by the same physician during the post-operative period. This is used when an unrelated procedure is performed during the post-operative period of the original surgery. Modifier 80 is for an assistant surgeon. It's used when a surgeon acts as an assistant surgeon. Modifier 81 is minimum assistant surgeon, used when minimal assistance is provided to the primary surgeon. 82, the assistant surgeon when qualified resident surgeon not available. This is used in teaching facilities when a resident is not available to assist the primary surgeon. Modifier 90 is for reference labs, which are outside the office. It's used for path and lab codes when specimens are collected or handled in the office and then sent out for testing. 91 is repeat clinical diagnostic lab tests. This is used only when a lab test is performed twice in the same day to track changes, not used for a series of tests or a panel. Okay, modifier 99 is indicative of multiple modifiers. This is used when payers don't allow submission of more than one modifier. If multiple modifiers are required to fully explain the circumstances, modifier 99 is appended and a special report is submitted to the third-party payer. Anesthesia physical status modifiers, these are your P1 through P6. They designate and distinguish the various levels of complexity of patients when receiving anesthesia. The anesthesiologist is the one that assigns this status. P1 is the lowest level and denotes a normal healthy patient, where P6 is the highest level and is used for brain dead patients whose organs are being harvested for donor purposes. Physical status modifiers are assigned always and are in the last position, if you will, of anesthesia codes. Okay, modifier 27 is multiple outpatient hospital E&M encounters on the same day, used when multiple E&M services are performed on the same day for different reasons. Again, the importance here is for outpatient hospital. You'll notice when you look at your modifiers that there is a distinction between outpatient and physician modifiers, who uses them and who doesn't. All right, modifier 73 is discontinued procedure prior to the administration of anesthesia. Used when patient's health status precludes anesthesia administration or if patient chooses to cancel the procedure. Modifier 74 is discontinued procedure after administration of anesthesia, used when surgery must be discontinued after the administration of anesthesia. Okay, HICPICS level 2 modifiers. You do have them that are specific to the anatomical area. The upper left eyelid is E1, lower left eyelid E2, left hand second digits F1, right hand fourth digit F8, left circumflex coronary artery is LC, right coronary artery is RC, the right side of the body or the organ that's being addressed is RT. Okay, HICPICS level 2 modifiers do provide specific details such as performance and payment of a screening mammogram and diagnostic mammogram on the same patient, same day is modifier GG, which you will find this. Not sure, yes, it is indicated on your quick at a glance listing in the front of your CPT manual book. Ambulance service provided under arrangement by a provider of services, and that's QM. Okay, so CPT 5, again, this is current procedural terminology, 5th revision, was initiated by AMA in 2000 to support provider reimbursement. It does provide data needed for development of best care practices. It does comply with EDI and EHR requirements under HIPAA. There's new code categories, which you have your Category 1s, Category 2s, and Category 3s. Category 1s are your traditional CPT codes. Your Category 2s are your performance measures and tracking codes. And then your Category 3 are your temp codes for new procedures and technologies. In order for a code to get into your CPT book, it needs to hit a threshold, if you will, meaning a number of times when they aggregate the data, and that it may hit it where it may just be a Category 3 code, but next year it may hit a threshold that catapults it from a temporary code to an actual CPT code. So again, that's determined. Again, that's why codes are revised annually and become effective January 1.